So, kia ora koutou, talofa lava o tō uma. It is Māori Language Week this week, apparently, which I wasn't aware of. So, I guess what I've done is sort of cobbled together a number of different talks that I've given. As I was mentioning to Marion, usually my talks are restricted to 15 minutes, so to have 2 hours is luxury, but I'm used to, I guess, rushing through things, so I'm really happy to slow it down, to answer any questions, to just deal with things as we go along. If you're a bit embarrassed about the camera, they won't sort of swing around and look at you, you'll just be a disembodied voice that they can't hear anyway, and I have to repeat the question. I came down last night and there was a bit of a jolt. A little earthquake, which of course is really untoward for someone from Auckland. And so I started wondering about how I would behave in front of the cameras, because of course if we're filming and there's a big one, it's going to be CNN, all of that. So I will stand up here and be extremely calm and direct you all to get away from the windows, get under the tables, and I'll just stand here and look pretty for the cameras. So that's enough of that. Just a bit about me. I'm a mother of 3 and a grandmother of 1, which is just amazing. It's lovely being a grandmother. I've just completed a graduate diploma in arts and Pacific studies, which has been really fun. And my big plan is to do a PhD on a culture-bound mental illness in Samoa and Tonga. So it's way away from maternal mental health, but not away from mental health. So let's see if I can work this. Yep. So this is really what I'm going to be talking about. First of all, a bit about what's different in pregnancy and postpartum, risk factors, the different disorders, a little bit about assessment and screening, quite a bit about management, which is a bit heavy on the medication side of things, so I can skim through that real fast if people aren't particularly interested. And then the cultural aspects, which are unashamedly directed towards Pacific, but I can talk briefly about other cultural aspects as well. So that's what I'm going to talk about. So, hormone-related mood disorders. One of the good things about hormones being involved is that it seems to slightly reduce the stigma associated with emotional issues. People can see it as being biological, which can be helpful. One of the things about mood disorders related to hormonal changes is that they can be much more variable than your common or garden depression. You're not necessarily flat all the time or anxious all of the time. And a couple of decades ago, one of my patients said, when you're good, you don't feel you need to ask for help. When you're bad, you just can't ask for help. And so that's something, I guess, to be aware of. Also, society has a lot of expectations of how you're going to be during pregnancy, over the moon, or if you're in difficult circumstances, oh, no wonder she's feeling like that because of X, Y, Z. And so women will often find it really difficult to express distress when they're supposed to be happy and people are saying, well, aren't you so excited about the new baby? Another thing is that you're supposed to feel exhausted after you've had a baby. And so the exhaustion that goes along with a depression may not be recognised as being part of a depression. So exhausted is one thing, but exhausted and defeated is another thing. You've also always got at least 2 patients. You've got your mum and your baby, or babies. You've also got other siblings, the partner, the grandparents, basically the whole family to be thinking about. And with the mother and baby dyad, the medication issues can be a very vexed question, because you're looking at trying to get mum feeling as good as she can, but also not opening yourself up to litigation if something goes wrong with the baby. So, risk factors. The biggest risk factor is a past history of a postpartum condition. So, depression for postnatal depression and postpartum psychosis. The next big risk factor for particularly postpartum psychosis is a personal history or a family history of bipolar disorder. And if there's one question, only one question that you can ask in an antenatal screening, that's the question to ask. A past history of depression generally increases your risk, and other I guess, specific risk factors for postnatal depression, as in postnatal rather than depression generally. Lack of social support, particularly if there's a difficult partner relationship, a history of premenstrual syndrome. Your relationship with your mother is an interesting one. It can be hostile, it can be absent, it can be idealised. I could never live up to that, but that's a specific risk factor for postnatal depression. Another really interesting one is ambivalence about work, whether it's about giving up work or returning to work. And also sexual reproductive trauma that can include childhood sexual abuse, rape, miscarriage, termination, a whole lot of different factors. So a little bit about bipolar disorder first, because this is the big one. Over the years, they found that women with bipolar disorder are more prone to, for instance, getting worse before a period and have a really high risk of becoming unwell postpartum. The other thing is that because of the age of onset of bipolar disorder is generally in your 20s or 30s, an episode of postpartum psychosis may in fact be your first episode of bipolar disorder, and you don't know till time has gone past. If you're well during pregnancy, your risk of a postpartum relapse is only about 70, as in 70%. But if you have clinical roughening during pregnancy, that is, you don't actually have to become unwell, but you can just have like subsyndromal symptoms of either depression or elevation, your risk of relapse approaches 100%. So that's why it's the big question. Also, unfortunately, the mood stabilisers aren't that good to be taking during pregnancy or breastfeeding. I'll talk in a bit more detail later about the medications, but if you're able to assist your women with bipolar disorder to plan their pregnancies, that would be really good. The good news is, though, that if you're aware of it, there are prevention strategies, which again we can talk about a bit later when I talk about medication. So, let's start during pregnancy. Antenatal depression. We used to think that pregnancy was a time when people glowed and were happy. That's not necessarily the case. About 10% of women experience, and I say proper depression, sort of clinical depression, other than just feeling a bit low. And that's, when I say depression, that's what I'll be meaning today. So about 10% of women have significant depression during pregnancy. And a third of women who experience postnatal depression were depressed during the pregnancy. There's the question of, is it difficult to diagnose? Again, I spoke briefly about expectations of how you're going to feel. And then there's the difficult question of hyperemesis. And so is the depression and anxiety exacerbating the nausea, or is the nausea causing the depression and anxiety? Who knows, but both have to be treated. Treatment can be a problem because often when women are very anxious, they will be concerned about something going wrong with the baby, and that can make them really reluctant to look at treatment. I've had a few women over the years, often the slightly older woman, who's gone to great lengths to get pregnant, for instance IVF or clomiphene, or really trying hard. Then she gets pregnant and becomes profoundly depressed and believes that she won't be a good mother and wants a termination. And all but one of those women, with some reassurance about, you can still have a termination if we don't get you better, we've got plenty of time, because at least when it's been sort of carefully monitored, you get the pregnancy really early. So in all but one of these women, they continued with the pregnancy and things ended up going well. But there seems to be a small subset of women, I don't have any research figures on this, I'm afraid, who are older, undergo hormonal treatment to get pregnant, and then become profoundly depressed during the pregnancy. And several of them also had hyperemesis. And they responded really well to appropriate medication, but required a lot of reassurance. And one of those babies is, I saw him the other day, he's about 12 now, and he's absolutely fine at this stage, so that's good. So, to move on to the anxiety, it's actually more common than depression in pregnancy, occurring in about 15% of pregnant women. And there's some reasonably robust research which shows that severe maternal stress, and anxiety sort of equals that, particularly in the second trimester and particularly between weeks 18 and 21, does have an impact on the baby. Basically you're looking at the baby being bathed in cortisol for a number of weeks, and it seems that during this particular part of pregnancy it does affect the brain and makes the baby less resistant to stress. And they've done the experiments with various small animals and also observed babies, because clearly you can't stress some mothers and not others and see what happens to the baby, but the babies did appear to be less resilient to stress, and that may end up being sort of a fractious baby or a timid baby. I'm not quite sure.
Can you talk about what you mean by stress? Because that can mean a lot of different things. So, I'm just thinking about the old midwives' myth of you shouldn't have any nasty shocks.
Yes. It seems to be. Yes, it seems to be more the prolonged stress. So being in difficult circumstances, having an anxiety disorder, anything that's going to raise your stress hormones, raise your cortisol. So having like a short, sharp shock, like a jolt, an earthquake jolt. Sorry, I'm a bit preoccupied with this. So one jolt is going to give us all a fright. Our adrenaline's going to go, our cortisol's going to go, but then it's going to calm down because we're going to be fine. If there was the big one and we couldn't get out of Wellington and we had to stay here for 2 weeks, that would be significant stress. Our cortisol would be raised, it would be bad for the baby's brain. So it's more the prolonged stress, and having an anxiety disorder where everything feels stressful, that fulfills those criteria. So probably having a black cat land on your head and having baby have a birthmark probably isn't, that's more an old, a midwife's tale. But having the ongoing stress does seem to be important. And in London, Yvette Glover did a lovely sort of experiment where she got people to have massage therapy and calmed them all down beautifully, and that was a good thing, and it was a pity we can't all do that. Okay. So, as I mentioned briefly before, the anxiety itself can be a real barrier to treatment. And if someone's hugely anxious, trying to do like cognitive behaviour therapy can just be pushing the proverbial uphill because the anxiety just overrides things. And so at least knowing we've got good evidence about the effects of stress on the baby, but no really robust evidence about adverse effects of the medications that we might use. I'll talk about that, as I say, later. Something that can present suddenly, often in later pregnancy, is reactivation of post-traumatic stress disorder, or specifically tocophobia, which is an unreasoning fear of childbirth. And of course can occur when you've had a previous traumatic birth. And like one woman that I saw presented at 37 weeks in a terrible state, having sort of repressed the memories of her previous traumatic birth and them all flooding out again, and not wanting to go to hospital to have the baby, not wanting the baby at all, and actually considering suicide as an alternative to going through labour. Luckily there's a magical treatment called eye movement desensitisation and reprocessing, which I'll talk about later. And literally she walked into my room in a terrible state and walked out fine. So that's pretty cool. Just briefly about assisted reproductive technology. Stress, and I'm not sure how people define that, that was just in the questionnaires that we used as the major reason for stopping treatment rather than adverse effects of any of the regimes. That stress seems to be around the expectations of what's going to happen as opposed to the reality of what does happen, and that the process, the sort of getting your expectations up, getting your hopes up, going in for all of these tests and things is probably more important than the actual hormonal effects. And also the pre-morbid personality seems to be important for the women who are getting distressed about this. Again, often the perfectionist, the older woman who's done everything before, like I saw these smiles and grins around the place, who's sort of done everything before having the baby. Those seem to be the risk factors for getting distressed around ART. So I'm just going to have a quick drink of water because I can feel my mouth is getting dry. Excuse me. Okay, so PND. The acronym is commonly used to describe everything. And I've met women who introduce themselves sort of like, hi, I'm so-and-so, and I've got PND. And this PND will be 5 years after having their last baby, and what they're actually talking about is they're having problems in their life, and it's a good way to describe it or not. The most worrying use of this PND thing is when someone actually had a past episode of postpartum psychosis, said, I had PND, is believed that she had PND, and then becomes really, really unwell on day 2 or 3 postpartum. That's when it's a worry. Because one of the good things about postpartum psychosis is it's about the only psychiatric emergency or only emergency that you've got 9 months to prepare for. It's also probably less stigmatised than other psychiatric diagnoses. So saying, I've got PND, people think, oh, that's a hormone thing, it's not your fault, we won't blame the victim here. There was a relatively recent tragedy in this country where my understanding is that the woman was told she might have a bit of PND. And she probably had either a psychotic depression or a postpartum psychosis. So it's not everything is PND. So worldwide, approximately 10% of women suffer from postnatal depression, which is a major depressive episode occurring postpartum. In this country, generally, our rate is 16%, and amongst Pacific women, it's around 30%. I'll be talking a bit later about the whole story of that, but basically the rates are alarmingly high in Pacific women. Postpartum psychosis occurs in 1 in 500 women, but in 1 in 3 women who have bipolar disorder. And if you've had a previous episode of postpartum psychosis, your rate rises to 1 in 5. There are also women who have ongoing conditions such as schizophrenia, anxiety, depression, OCD, who aren't going to magically get better just because they're pregnant and are going to possibly suffer relapses because of the hormonal effects. Other syndromes such as postpartum post-traumatic stress disorder, postpartum obsessive compulsive disorder, and other anxiety disorders. The 3rd day blues are basically normal, and they occur in 80% of women. And the other thing which need to discuss is the vicissitudes of motherhood. You know, it's not all a walk in the park having babies. So there probably should have been a heading on that slide, but I didn't put one on and I can't remember what it should have been. Okay, so postpartum obsessive compulsive disorder is obsessive compulsive disorder that occurs specifically postpartum, often with quite a dramatic onset, in which the woman experiences recurrent intrusive worries that she may harm the baby, usually with a lot of anxiety and guilt. How could I think these things? I've had women who, while bathing the baby, suddenly imagine themselves drowning the baby. Or I had one father, and this is the only man I've met who had it, who had this recurrent intrusive thought that he might stamp on the baby's head. And you can imagine the awfulness of having that sort of thought. And of course, it can, if the woman doesn't admit to it, which she often won't because of fears that the baby will be taken away from her, they can go to huge lengths to keep the baby safe. And when I did a little study on this women were doing things like getting older children to keep all the kitchen knives in the garage and get them out when she needed them for cooking. Another woman who wouldn't let the baby on the floor, and when I first met this woman, the baby was about 18 months old and literally wasn't moving around because it had been kept off the floor, or not being alone while bathing the baby, or not being alone at all. Generally, if the thought is, what if I do this, or I might do this, and it's not accompanied by an urge to do it, which is a completely different kettle of fish, then that woman isn't a risk to the baby. And this condition's very easily and effectively treated with SSRI medications, with or without low-dose atypical antipsychotic medications, and with cognitive behaviour therapy, that a thought doesn't mean it's real. In a series of women who had the thought that they might sexually abuse the baby, it was interesting because I would have expected more of those women to have been sexually abused in the past if they were going to worry that they would sexually abuse the baby, but actually it was more that they'd been physically abused or subject to harsh corporal punishment. And the main risk factor for having postpartum OCD seemed to be being a teacher. Literally 2/3 of these women were teachers, or childcare workers, or nannies. Sort of interesting, isn't it? And so I guess my sort of wondering, possibly a bit simplistic about that, was that maybe you're used to controlling a whole classroom of children and then you can't manage your own. Being a nurse wasn't a very good, well, that was the next most common occupation. Yeah, and I had one doctor who, yeah, So postpartum post-traumatic stress disorder. This is something which I guess there wasn't even a word for when I first started doing maternal mental health about 20 years ago. Sorry, no more than that, about 30 years ago now. Goodness, I'm getting old. And so there seemed to be a number of women who were presenting with depressive and anxiety symptoms who weren't getting better with what we were giving them. And there was the thought, oh, they've got personality disorders, or they're just difficult, all those other things. But what came out was that they were having recurrent intrusive memories of the birth. And so they'll often present with depression, because we all know about PND, but it's more than that. And so asking specific questions around the recurrent intrusive thoughts, or even how was the birth? Do you keep thinking about it? And also remembering that we, well, I don't, but I guess you guys attend births almost every day, and so what's normal and routine for you may be hugely traumatic for the woman. And it can go on for the rest of your life. I remember meeting a 70-something-year-old woman who was referred because she had huge anxiety around having her blood pressure taken, and she was hypertensive at 70-something. And she ended up being able to tell me that during the delivery of one of her children, she had a hemorrhage, and they said, we're losing the blood pressure. And so having the blood pressure taken was hugely distressing for her. So the implications of postpartum PTSD, there's tocophobia, the phobia of having another baby. The effects on relationships, look what you put me through, sorts of thoughts about the baby, or even seeing the baby, reminding them of what happened. Also the impact of PTSD on the relationship with other children, relationship with the partner. Litigation is a not uncommon side effect of PTSD, looking for someone to blame, trying to get closure, trying to make it right. And probably at least 50% of women with postpartum PTSD also have coexisting depression, and anxiety is just a part of it as well. So you have to have had the traumatic birth experience, and as I say, you might not think it was traumatic, but they do. And interestingly, one of the main things that women say about the traumatic birth is that panic, or perceived panic on behalf of the birth attendants, was one of the main things that really wound them up. The intrusive phenomena can include dreams or nightmares, flashbacks. So the common one is if you've had a big bleed is, you know, when you get your first period after having a baby, blood in your undies takes you right back there. Hyperarousal, being anxious, irritable, not being able to get off to sleep, and also the sense of emotional numbing, not being able to feel close to anybody, including your baby. So treatment is again the SSRIs, selective serotonin reuptake inhibitors. The most common one is fluoxetine or Prozac, which you probably have all heard of, and also low-dose atypical antipsychotics. And the word antipsychotic is pretty scary, but at low doses, these medications are pretty good for stopping stuff getting in, like these recurrent intrusive thoughts, flashbacks. They can just put those to bed. And we're looking at much, much lower doses, so I'll talk really briefly about that later. Cognitive behaviour therapy, this EMDR, which I will explain in a moment. And also validation that they're not crazy or stupid or wussy or whatever to have these symptoms, explaining what happens in PTSD, and also knowing about it really helps. So eye movement desensitization and reprocessing is a specific treatment for post-traumatic stress disorder. And the sort of face valid theory behind it is that when you are traumatized, your sleep gets messed up. You don't have the rapid eye movement sleep, which sort of processes what happens yesterday, so it's gone, it's dealt with, and it's not in your face tomorrow. So the way that we do this...
Sorry, what was the R? Eye movement.
Desensitization and reprocessing. Yeah. So the way this sort of magical thing works is to hold the image plus the thought, I'm going to die, and the feeling, terror, in your mind while you watch the person's hand. And so this side-to-side movement of the eyes somehow seems to process the trauma into then and there rather than here and now. And they've done like functional PET scans which show that you remind the person of the trauma before the treatment and their amygdala lights up, and then post-treatment it doesn't. It's pretty clever stuff. And it's also really good for use in pregnancy and postpartum because it doesn't get into the breast milk and doesn't cross the placenta. And so you don't really need to worry about adverse effects on the baby, and it works really quickly. As I say, literally, if it's a one-off trauma, you can walk into the office terrified and walk out feeling okay. So that's my plug for EMDR.
Practitioners that do this therapy, is it in the general population or not a widespread therapy?
It's getting wider spread. They now do trainings twice a year in New Zealand, and so it really a lot matters on where you are as to whether the person in your local community mental health centre, if they've got someone who does EMDR. Like up in Auckland, if your woman lives in Taylor Centre area, they do have a psychotherapist who does do EMDR. If they have money, a number of private practitioners do EMDR. And ACC is still not that keen on it, even though you'd think they would because it works quite quickly, but they're gradually starting to come round to it. So
what you're talking about is that you're bringing a past experience into the present and linking it into movement, like anchoring.
Well,
it's sort of anchoring. Just that I get an understanding.
Yeah. It seems that in order to process it, to get rid of the sort of immediacy of it, the side-to-side movement somehow does that sort of connection between the amygdala, the emotional part of the brain, and the prefrontal cortex, the thinking part of the brain, somehow sort of links them up so it's, oh yes, that happened, it wasn't very nice, but it happened, rather than, it's happening again, and all those feelings happening without your thoughts being able to say, no, it's okay, it's not happening now. Basically. That's a great way of putting it, yeah.
So does it tend to be better for people who haven't got a kind of personality style where they're a constant worrier and kind of experience these things most of their life, or as opposed to someone who this has just been brought on?
Yep. The times when it's probably best not used, or certainly not by sort of young players, is when the woman has a past history of significant trauma like childhood sexual abuse or recurrent domestic violence, it works best for a one-off thing. And basically if the person is an anxious person, as long as they're able to tolerate the feelings that come up during the process, then I don't know that that actually makes any difference. It's if they've had recurrent trauma that it's a problem.
And I just had one other question. You might be going to deal with this later though. You've got the SSRIs and low dose respiratory. Do you start with the SSRIs or sometimes do you do a combination right from the start?
Okay, I'll often do a combination right from the start, depending on the degree of intrusion and sleep issues. Okay. So looking at screening and referral, I mean the basic question is, who should be referred to a psychiatrist during pregnancy, and the answer is those who present with symptoms and women with a history of serious mental illness, particularly the bipolar disorder. So with our screening, as I've said, the big one is the anyone in your family or you yourself having a history of bipolar disorder or postpartum psychosis. But sort of more generally, a history of mental health problems, which you might have to ask fairly tactfully because people don't necessarily want, just the word mental, particularly with our Pacific people, they're just going to turn off immediately because even mental health is stigmatising. So these questions were from guidelines, and I think I say next that guidelines are useful somewhere. So I would really ask, how are you? Did you have any problems, after your last pregnancy? Has anyone in your family ever had any emotional problems or anxiety or depression? It really should tailor it to the person in front of you. And also it doesn't have to be asked straight out on the first visit. It can come up in conversation. The main thing is you don't want people to feel stigmatised, but you also don't want them to become horribly unwell, leading to tragic situations if you could have prevented it. So as I've talked about before, the Edinburgh Postnatal Depression Scale is quite a good screening tool. In this country we don't have it as a sort of mandated screening process. I'm not sure why, but we don't. It's a 10-item self-report questionnaire which is available in a lot of different languages and has been validated in some, including Samoan and Tongan. It's only screening, it doesn't replace clinical opinion, but you can use it during pregnancy as well if you're concerned about how someone is. Anxiety may score high, which is fine because we want to detect anxiety as well as depression. We're looking for whether there's a problem here, not what the diagnosis is, but it doesn't detect psychosis. That's what it looks like. Basically it's a tick box. It takes literally about 2 minutes to complete. It's scored between 0 and 3 and the usual cut-off is around 10 to 12 depending on the ethnic group you're looking at. It seems to be quite well accepted by people. There were concerns with the Pacific women whether they wouldn't like it because it was written down, but actually it was apparently easier to endorse otherwise shameful items such as the thought of harming myself has occurred to me. They were able to tick the box, whereas if they had been asked face to face they wouldn't have felt able to. So as far as referral goes, I know that we've got people from right through the country here, and a lot depends on where you come from as to what's available. And also it depends on the severity of the condition. The public system is generally supposed to treat the worst 3%. And if we're looking at 16% of women experiencing diagnosable postnatal depression, it means that most of them are going to fall below the threshold. Well, maths isn't my strong point, but anyway. Also the stage of pregnancy. Generally maternal mental health teams don't take people until at least part way through the second trimester. And The Auckland maternal mental health teams will take someone up to a year postpartum, but of course if you're presenting at 11 months postpartum and are going to be moved on after a month, that's not very satisfactory either. Generally, people are able to be referred by their LMCs or other health professionals. It doesn't have to be a GP, although some places I think still do want it to be a GP referral. Some take women just on their own referral. The main thing about getting your referral accepted is to give as much information as possible. And if you've actually done an EPDS, that can be helpful. You know, she scores 22 on the EPDS is going to be a lot more sort of punchy than I think she might be depressed. Also, the woman and her family need to be on board with the referral, because there's no point whatsoever in referring them to the maternal mental health team. They phone up and she says, what are you on about? Also the family as well, because if there's someone saying, no, there's nothing wrong with you, I felt like this with all of my 16 children, that's not going to work either. So doing a little bit of preparation can be useful. So we've got the DHB maternal mental health teams. I guess where you guys come from all over the place. Do all of you have maternal mental health teams with the DHB? No?
Define team.
Ah, okay. Okay, because like with the teams in Auckland, originally it was sort of part of a psychiatrist and a couple of nurses. The biggest, I've got head shaking here. Counties Manukau at one point devolved the team and had 0.1 of a psychiatrist who was doing a locum, which lasted for 4 years. Half a day a week wasn't a good look, and one designated person in each of the maternal mental health teams. So a team will be someone who has the title maternal mental health. No, so somewhere. You haven't even got a cat team?
No, that's all.
Oh, just the cat team. Okay. So the crisis or community assessment teams are also there we go. Can also be useful, but again, it depends who you get on the day, and they may well not have the particular awareness that if someone sort of might be psychotic at 4 days postpartum, sort of might be needs immediate assessment, whereas if they haven't got a small baby around, maybe they can wait 2 days or even 2 hours. Mother-baby units, Christchurch has one. Auckland is supposedly developing one in time for the election. Yeah. NGOs, non-government organisations and respite. In Auckland there's a non-governmental organisation called Affinity who actually has a small mother and baby specific respite unit, which is pretty cool. They can also often offer support for the woman and her family, although sometimes they will say they offer that support when actually they don't offer anything more than generic support. The District Health Board cultural teams, like me, I did actually work with maternal mental health for ADHB. I worked for the Pacific Mental Health team, and we would tend to keep our women on or take referrals directly, I guess because they've got me there, so I have a certain amount of knowledge about maternal mental health. Rather than having the woman go to the general team and not feel comfortable. The sad thing is that looking at the numbers of Pacific women in the Auckland District Health Board's maternal mental health teams, very few indeed have presented to them or been taken up by them, whereas we're looking at about double the rates of mainstream. So what are happening for these women? I will be talking about that later. There's also the private sector. If someone has a lot of money or wealthy parents or overseas insurance, New Zealand insurance doesn't really help, then they may be able to afford private psychiatrists, private psychologists, even private postnatal depression support groups. But that's if you've got money. There's also some pretty good peer support in different areas. In East Auckland, there's a group of mums who actually make dinners for other mums and things, which is really, really cool. Things like the postnatal, I think it's postnatal distress support network. There's a number of different ones in different areas. So really, I guess, getting to know what's available in your area and linking the mum in with those. So my timing is absolutely perfect, clearly. Any questions about that sort of referral and screening?
So, do you have any advice when your referral, from I'm sure other practitioners have experienced it when it isn't acted on, as to how to try and get a response? Like maybe the woman isn't quite severe at this point, bad enough, but you know that you're going down that pathway, and you just can't get her seen by anyone.
The wording is useful. Things like grave concern, risk, prudent. It would be prudent to get this woman seen as soon as possible, as I have grave concerns about her deteriorating and becoming a risk to herself or her child.
But I think one of the things that they want to know, having experienced it not so long ago, about a couple of years ago, is the question they ask you when you do that, and this is, I'm talking from Auckland really, is she going to kill herself or harm herself or the baby? And you don't know that, but they are at a time where they're very unwell, but you don't know whether they're going to do that, or you don't get a sense that that's where they're going. And I remember having this conversation with the maternal mental health team, and the thing was, yes, we'll come and see her, and I said I really would like somebody to see her, so she has a point of contact and knows who to call once she's discharged from this facility. And it was a continuous thing, and I had to sit there for a good hour to try and explain to them, sort of saying, and eventually they came the following day. And I think it's really important, like you said, Sarah, that the family are on board, because the woman may be on board, but at the time, it may want at that time for you to do a referral, so she's able to see. But once the family comes, then that may change too, and recognize that. Because of, like you said, the family. But it is quite hard. They do want somebody to be in real crisis point. And I had to keep saying, look, she's not, at the moment I don't get a sense she's going to hurt herself or the baby, but she is very, very unwell.
So I guess if someone was to say that to me, is she going to kill herself or the baby? I'd probably say something like, I sincerely hope not. That's why I'm referring her to you now. Absolutely. Yeah, and so I guess things like even just having an EPDS score to show that you're not just saying, oh, something psychological, I'm passing it on, to show that you've actually done a little bit of an assessment. Yeah, and I'd definitely say, if as a midwife or child provider, you're not getting any luck, to get right onto the GP, because then also if the specialist team is saying, well, we can next week or we can tomorrow, then at least the GP could then prescribe something to make her go to sleep, so that at least she's asleep until she can have the assessment. So, yeah. Yeah. The EPDS has been validated in a number of different populations during pregnancy, so it's a good screen to use. I guess different people, different groups of people have different rationales. Like some people would say, well, it's only going to be 10 items, just give it at each antenatal visit. Other people would say, 16 weeks, so that you get that window of vulnerability for stress, so do it before that, and then again at say 28 weeks or so you're looking at, are we heading into having the baby depressed. Probably personally that's what I would do, because when I see women during pregnancy, I tend to see them as soon as they get pregnant, so we can deal with the medication, at about 16 weeks, so we can make sure that they're fine, and then again at about 28 weeks to look at a sort of an interim birth plan, and then again at about 34 to 36 weeks. That's what I do. I guess it's sort of up to you is what I would say, but that's when I would do it.
Are you recommending that for everybody or just those with high risk?
Well, again, if it's screening, you give it to basically everybody. And is it such, I guess my thing is it such a big deal? 10 items, tick the boxes? Is it such a big deal? Sort of a second to score? But the question is, what do you do with it when you get a positive response? Because you're not going to get everybody who scores 12 plus into a maternal mental health team.